In this topic, we are going to learn about the shoulder joint in detail. So, the shoulder joint is just not a single joint, but it is a shoulder complex where it consists of the shoulder joint or the glenohumeral joint, acromioclavicular joint, sternoclavicular joint. This is sternoclavicular. This is acromioclavicular. This is the glenohumeral joint, and it is the scapulothoracic joint, this one, which is between the scapula and the rib cage. So the movements of the shoulder joint occur in congruence with all these joints. So before we go on to the glenohumeral joints, we'll just know a bit about the other joints too of the pectoral girdle. So the acromioclavicular joint, it is a synovial joint that is formed by the articulation of scapula, the acromion process of scapula, with the lateral end of the clavicle. And the sternoclavicular joint, this joint is formed by the articulation of the medial end of the clavicle to the clavicular notch of the manubrium sterni. So these two joints, they play a vital role during the abduction of the limb at the shoulder joint beyond 90 degrees. So we'll see that in detail as we go ahead. Now coming to the scapulothoracic joint. This is formed between the anterior surface of the scapula and the ribcage or the thoracic wall, the scapular muscles. This scapulothoracic joint is not articulating with bones as such. So this joint is called as false joint or pseudo joint, because there is no typical joint characteristic features like articulating bones and a joint cavity and the synovial fluid that is between the articulating surfaces, so on and so forth. It's not a typical articulating joint, but is considered as a unit that gathers the sternoclavicular joint and acromioclavicular joint, and is the junction, actually it is a junction between the anterior surface of the scapula with the thoracic cage. So we can also call the scapulothoracic joint actually as scapulothoracic junction. And the main function of this scapulothoracic joint or junction is to center the socket part of the shoulder joint with the ball of the arm during elevation of the arm. That is the main important feature that is contributed by this scapulothoracic joint. Before we go, let us just see what a normal shoulder anatomy looks like. Like any other joint, it has a joint cavity. This is the joint space in which synovial fluid is there, and these are the articulating surfaces which are lined by the articular cartilage, which is the hyaline cartilage without the periosteum. That is the characteristic feature of the articular cartilage. The peculiarity of the articular cartilage here anywhere is it is lined by hyaline cartilage without periosteum. And then the joint cavity is surrounded by number of the ligaments and surrounded by the muscles, keeping the joint articulating bones in proper anatomical position. So this is the humerus that is articulating with the glenoid fossa of the scapula, this one, which is a shallow pear-shaped structure and is made mainly in line or in anatomical position by these four muscles, which are called as rotator cuff. In other words, it can be called as guardian of the joint. The rotator cuff is called as guardian of the joint. So let us now see the glenohumeral joint or the shoulder joint in detail. So the overview of the glenohumeral joint is, it is a synovial ball and socket type of joint between the head of the humerus and the glenoid cavity of the scapula. These are the articular surfaces which are lined by the hyaline cartilage. And the stability of this joint, as said, is by the rotator cuff. So it is also called as the guardian of the the joint, and is also made stabilized by the long head of the biceps and all other surrounding extracapsular ligaments. And this joint, being synovial, has movements that occur at this joint. They are the flexion, extension, abduction, adduction, medial rotation, lateral rotation, and combination of all these joints is the circumduction. And as you can see, the ball of the head of the humerus is much larger to the socket of the glenoid cavity of the scapula. So as the articular surfaces are not fitting in properly as ball and socket, the shoulder joint is the least stable joint among most of the other joints in the body and is most movable joint. So the stability of the shoulder joint is compromised for the mobility of the joint, and the joint becomes close packed with full congruence of the articulating bones in abduction and lateral rotation. In a pendant limb, it is an open pact. So the anatomy of the glenohumeral joint or the shoulder joint should be studied under following headings: location of the joint, type of the joint, bones forming the joint, articular surfaces, ligaments of the joint, relations of the joint, blood supply and nerve supply of the joint, movements and the muscles responsible for the movements of the joint, and clinical anatomy. The glenohumeral joint is an essay question where it can have sub questions, the short questions within this. So let us see it in detail. The location is at the shoulder region. What is the type of the joint? It is a multi-axial ball and socket type of synovial joint between the head of the humerus and the glenoid cavity of the scapula. What are the bones that are forming the joint? The ball of the ball and socket joint is formed by the spheroidal head of the humerus, and the socket is formed by a pear-shaped small and shallow glenoid cavity of the scapula. The articular surfaces. The ball is formed by the spheroidal head of the humerus, which forms 1/3 of the sphere, and the head is directed medially upwards and backwards, and is covered by the hyaline cartilage, which is thick in the center and thin towards the periphery. Now the socket. It is a pear-shaped, small and shallow glenoid cavity of the scapula, which is directed forwards, upwards and laterally. The hyaline cartilage, which is lining the glenoid cavity, is thin in the center and thick at the periphery, just the opposite of the head of the humerus, the hyaline cartilage that is lining the head of the humerus. Then the fossa is deepened by glenoid labrum, which is a fibrocartilaginous structure attached to its peripheral margin for the head to sit properly in the socket. Only 1/3 of the humeral head comes in contact with the glenoid cavity at any position. The narrow upper end of the glenoid cavity encroaches onto the root of the coracoid process and has a supraglenoid tubercle which has an intracapsular origin of the long head of biceps brachii, and the anterior margin of the glenoid fossa is notched for the tendon of subscapularis. And in the lower end, the broad lower end has an infraglenoid tubercle which gives an origin to extracapsular origin of long head of the triceps brachii muscle. Coming to the ligaments of the shoulder joint, they are the fibrous capsule, the synovial membrane which lines the fibrous capsule, the glenoid labrum, glenohumeral ligaments, coracohumeral ligament, transverse humeral ligament. So this is what is the shoulder joint. So this is the coracohumeral ligament. The one which is covering the shoulder joint is the capsule, and these are the glenohumeral ligaments, and this is the transverse humeral ligament. So the fibrous capsule, it is considered as loose, lean and lax to permit the free movements of the joints, foregoing the stability which is taken care by the ligaments and muscles surrounding the joint. Attachment of the fibrous capsule medially is, it is all along the peripheral margin of the glenoid cavity outside the glenoid labrum, which includes the supraglenoid tubercle, which gives origin to the long head of the biceps. So it becomes the intracapsular origin and it excludes the infraglenoid tubercle, which gives origin to the triceps. And its attachment laterally is to the anatomical neck of the humerus, which is deficient at two places, that is the upper end of the intertubercular sulcus, which gives access to the passage of long tendon of the biceps, and inferomedially it extends about 1 centimeter below to encroach upon onto the surgical neck of humerus. So this is what is the attachment of the lower part of the capsule, which is loose and lax, however, is least supported and separated from long head of triceps by the axillary nerve and posterior circumflex humeral artery. The lower capsule, this lax capsule, it becomes stretched during abduction and forms a common site for the dislocation of humeral head in violent abduction. Let us now have a word about the rotator cuff of the shoulder joint, which is called as guardian of the shoulder joint, which keeps the head and socket in position. And these rotator cuff muscles, they blend with the capsule, the fibrous capsule, strengthening the fibrous capsule anteriorly, superiorly, and posteriorly. So this rotator cuff is formed by four muscles. It is supraspinatus, infraspinatus, teres minor, and subscapularis. Sit, it can be remembered by sits muscles as a mnemonic. Supraspinatus, infraspinatus, teres minor, and the subscapularis muscle. All these, they are taking origin from the scapula and they get inserted around the head of the humerus, keeping it in position to the socket of the scapula, that is the glenoid cavity. In this picture, you can very clearly see the blending of the rotator cuff muscles with the fibrous capsule at its insertion, which keeps them in position, the articular bones, and strengthens the capsule as well. Coming to the synovial membrane, it lines the inner surface of the joint capsule. The red dots is represented as synovial membrane. You can see here in this picture. So it lines the inner surface of the joint capsule and reflects from it onto the glenoid labrum. The synovial membrane doesn't line the articular surfaces of the bones that are participating in the joint formation. The synovial cavity of the joint, it shows following features. And then it forms a tubular sheath around the tendon of biceps in the bicipital groove, and it communicates with the infraspinatus and subscapular bursa. So it is a common feature of communication between the joint space and the subscapular bursa, and occasionally it has its communication with infraspinatus bursa also, which is here. This is the infraspinatus muscle. So the bursa is present between the infraspinatus muscle and the fibrous capsule. These bursa's main function is to reduce friction between the muscles and the surrounding structures, whether bones or cartilages, for restriction-free movements. So this subscapularis bursa, this is the subscapularis muscle, and this is the subscapularis bursa between the muscle and the fibrous capsule. So the communication is a common feature, constant feature with the subscapularis bursa, where the infraspinatus bursa occasionally has its communication with the joint space. So this is what is about the synovial membrane. I repeat again, the synovial membrane, it lines the fibrous capsule, and on the medial side it reflects on to the glenoid labrum, and laterally it is attached to the humerus till the articular surfaces, lining the fibrous capsule. So there are three apertures in the joint capsule. That is the opening between this one, the tubercles of the humerus for the passage of tendon of the long head of the biceps, and there's an opening that is located antero-inferiorly to the coracoid process. This is the coracoid process. Antero-inferiorly there's an opening to allow communication between the synovial cavity with the subscapularis bursa, this one. And occasionally, as said, there can be an opening located posteriorly to allow communication between the synovial cavity and the infraspinatus bursa. So coming to the glenoid labrum. This is the glenoid labrum, which is attached to the peripheral margin of the glenoid cavity. It is a fibrocartilaginous ring. It is made up of fibrocartilage and is attached around the margins of the glenoid cavity and appears triangular in cross section because it is thick in the periphery and thin and sharp at the free edge, and is continuous above with the intracapsular origin of the long head of the biceps. And this deepens the cavity for the articulation of the head of the humerus and protects the edges of the bone. And this glenoid labrum is also lined by synovial membrane. This is how it makes the socket more deeper, so that the head can be in position within the narrow, shallow glenoid cavity. This is how the dissected specimen looks like. This is the glenoid fossa or the glenoid cavity, and this is what is the glenoid labrum, which is in continuation with the long head, the intracapsular origin of the long head of the biceps, and this is the 1/3 of the spear of the head of the humerus that articulates with the glenoid fossa. So at any particular moment, it is only 1/3 of this head of the humerus is in articulation with the glenoid fossa. Coming to the glenohumeral ligaments. These are 3 in number: the superior glenohumeral ligament, middle glenohumeral ligament, and inferior glenohumeral ligament. Here you can see superior, middle, and inferior glenohumeral ligament. As the name implies, they are attached to the glenoid cavity and the humerus, glenohumeral ligament. They are nothing but they are the thickening of the anterior part of the fibrous capsule. And these ligaments, they can be best seen from within the joint. And these, they converge upwards and medially to the superomedial margin here of the glenoid cavity and blends with the fibrous capsule. The superior band, this one. It lies parallel to the anterior edge of the biceps tendon. This is what is the biceps tendon, the long head of the biceps, which is passing through the intertubercular sulcus. Okay, so the superior band lies parallel to the anterior edge of the biceps tendon and is attached to the upper end of the lesser tubercle. This is the lesser tubercle, this is the greater tubercle. So the one between the lesser tubercle and the greater tubercle is the bicipital groove or intertubercular sulcus, which lodges this tendon of the long head of biceps. So now this middle band or the middle glenohumeral ligament, it is attached to the lower part of the lesser tubercle. It is also known as Flood's ligament. The inferior glenohumeral ligament is attached to the lower part of the anatomical neck of the humerus here, and it is also called as Chalmers ligament. The subscapular bursa communicates with the synovial cavity between the superior and middle glenohumeral ligaments. Coracohumeral ligament. It is a thick band. This one is the coracohumeral ligament. In the upper part of the capsule, extends from the lateral border of the coracoid process to the anatomical neck of the humerus between the lesser and greater tubercles and blends with the transverse humeral ligament as well. This coracohumeral ligament can resist or withstand the lateral rotation and adduction movements. The transverse humeral ligament. This is the transverse humeral ligament. So this connects the lips of the upper part of the intertubercular sulcus and acts as a retinaculum for the passage of the tendon of the biceps, keeping it in its anatomical position. So this is the summary of the shoulder joint with articular surfaces and its ligaments. Quickly, the articular surfaces of the glenoid cavity and the head of the humerus, which forms the 1/3 of the spear, and the glenoid cavity is a shallow pear-shaped fossa. The ligaments being the capsule, which is lean, lax and loose, the glenohumeral ligament, the coracohumeral ligament, the transverse humeral ligament, and the glenoid labrum, which is a fibrocartilage which deepens the shallow cavity into a cup-shaped structure. And in the glenohumeral ligaments, the communication between the superior glenohumeral ligament and the middle glenohumeral ligament, it has communication with the subscapular bursa to the synovial cavity, and that foramen is called as foramen Wittbert. So this is what is a brief summary of what we have learned till now.